Good afternoon, and thank you to the organizers for inviting me to this conference. I am tasked to discuss the latest management guidelines for children with COVID-19. Presently, we know that we have an increasing number of COVID cases again, brought about by the emergence of Omicron variant sublineages. In terms of children, we can see from this graph that taking all cases since the start of the pandemic, they comprise a smaller number of cases compared to adults. They also comprise less of those who died due to the disease, with the careful note that children ages 0 to 4 have more deaths compared to other pediatric age groups. The American Academy of Pediatrics has this breakdown of cases differentiating between adult and child cases, and we see that by looking at the rightmost part of the graph, since the Omicron variant emerged, there were more cases in children. And it has also been observed that there were more hospitalizations, especially among the unvaccinated less than 5 group. We do not have this breakdown of cases for our local data. The Pediatric Infectious Disease Society of the Philippines, however, has local data, albeit a small portion of the total in the country, in the Salvation Registry. The registry data is mostly from hospitalized children. From this March update, it shows that most children recovered and less than 15% get severe or critical COVID. Note that the less than 5 age group comprise a sizable portion of these hospitalized cases. The comorbidities are seen on the bottom part. These observations are similar to other countries. The rapid response to the pandemic has allowed us to develop and also rapidly update the management of COVID. And so I will be using recommendations from these references, ranked from youngest to the oldest, with the caveat that most of the data are from studies done on adults, and that a lot may still change once new data arrives. And while a lot has changed, some have remained the same, like the WHO case definitions. A suspected COVID case is one who has symptoms of COVID and with epidemiologic exposure, like living in high transmission settings such as now here in the Philippines, or having severe acute respiratory illness. A patient may be classified as probable COVID when there is contact with a confirmed case, such as our sample case. We test a suspected or probable COVID case to confirm the diagnosis. The advice of the AAP is for patients who have symptoms consistent with COVID-19 to be tested immediately, without regard for vaccination status. The Salvation Registry data shows that, like in other countries, fever and cough are the most common symptoms of COVID in children. Different variants may present with different constellations of symptoms, so it would be interesting to know how this would be reflected in our local data. In the US, for example, recent variants appear to be associated with cru manifestations. Patients who are asymptomatic but have had close contact with a confirmed or probable COVID case should be tested at least 5 days after last exposure, or immediately if they develop symptoms. Patients who are required to obtain screening tests, meaning tests for asymptomatic individuals, based on implemented guidelines by authorities, should be tested as recommended. Vaccination status may, of course, affect decisions about the need for screening tests, and testing guidelines would be applicable here. RT-PCR is the gold standard diagnostic method. A nasopharyngeal swab specimen is the specimen of choice. Saliva specimen or mid-turbinate swabs may be alternatives for PCR based on the Philippine COVID-19 living recommendations for pediatrics. The rapid antigen test, on the other hand, is recommended for use under these conditions in patients with suspected COVID-19, symptomatic, and within 7 days from symptom onset, and using brands that have high sensitivity and specificity. Once a patient tests positive for the virus via PCR or antigen, they will be classified as confirmed COVID-19. This is an important question. Does recent SARS-CoV-2 infection impact decisions about COVID testing? Emerging data from the US suggests that reinfections within the 3-month window from the last infection are more frequent with recent variants, notably Omicron. and may occur at higher rates in young unvaccinated individuals. Children, we know that children who have had laboratory confirmed infections in the prior 3 months may continue to have positive test results, even in the absence of current infection, especially when using PCR. So, in a child with known exposure and compatible symptoms, there may be situations in which it's reasonable to retest even within the 3-month window. And if testing is performed within this window, the AAP recommends antigen testing because of the potential for false positive results attributable to prior infection when we use PCR. Or if you think about it, we can use the two tests in tandem. COVID-19, once confirmed, should be classified based on severity to guide us on the next diagnostic and treatment steps. These criteria are the same as the ones used ever since 2020 with a few changes. Mild disease presents with upper respiratory tract infection-like manifestations, and once there is pneumonia based on physical findings and or imaging findings, the patient is classified as moderate. Severe disease is present if there is oxygen saturation of less than 95% or if there is severe respiratory distress. The PSP guidelines has used 95% as cutoff because this would align with the PCAP guidelines. The PSMID guidelines, on the other hand, use 94%, while the WHO states that while it uses 90% as cutoff, this threshold to define severe COVID is arbitrary and should be interpreted cautiously based on patient status. Patients who present with ARDS with the following criteria or those defined to have sepsis or defined to be in septic shock, using the same criteria we use for other diseases, are classified as critical COVID disease. Patients with acute thrombosis are also classified with critical disease. This occurs rarely in children. Multisystem inflammatory syndrome in children, or MIS-C, is a sequela of acute COVID infection and is considered a critical disease manifestation and is diagnosed using the following criteria by the WHO. We manage patients based on disease severity. So, if a patient is classified to have mild COVID, symptomatic treatment is recommended. Antipyretics may be given for fever and pain. The child should be provided with a balanced diet and proper nutrition, as well as adequate hydration. Essential vitamins and minerals may help boost the immune system, but are not suggested to prevent infection or prevent disease progression. The DOH has made available home treatment guides for mild COVID. For my patients with mild COVID, I also prescribe Lagundi with the following dosing. There is data from a small study sponsored by DOST PCHRD showing the benefit of Lagundi for mild COVID cases. Patients treated at home should be well advised on what warning signs to watch out for. If there are symptoms like difficulty of breathing, seizure, signs of dehydration, the child should be brought to hospital. Patients with mild COVID do not need any other further laboratories. Some authors would suggest looking at the stage of disease the patient is in to guide the corresponding management. So if you look at this figure, vaccines, antivirals, and monoclonal antibodies may prevent progression to severe disease. The antivirals and the MABs are especially useful when given early in the disease. MABs prevent the virus from interacting with the ACE2 receptor, while antivirals stop viral reproduction. Meanwhile, on the right part, immunomodulators and anticoagulation are useful in the second or later stages of the disease when there is hyperinflammation. The therapeutic recommendations have changed a lot. The monoclonal antibodies used before are no longer recommended because they are not effective against Omicron. But we do have other antiviral options for mild or moderate COVID-19. Paxlovid and molnupiravir are oral antiviral medications which are indicated in patients at risk to develop severe COVID and should be given within 5 days of symptom onset. Molnupiravir is only licensed for those ages 18 and above, so this limits its use in pediatrics. While Paxlovid, on the left, although indicated for those ages 12 and above with the following other criteria, is limited in use due to its cost, its many drug interactions, and is not readily available in the Philippines as well. The AAP and the WHO prefer Paxlovid over molnupiravir in their recommendations. In the US, there is bebtelovimab, a monoclonal antibody that can be used within 7 days of symptom onset. Variants of concern that have rendered previous monoclonal antibodies like casirivimab and imdevimab ineffective have emerged. And so this begs us the question of how about the present circulating variants? Luckily, this in vitro study suggests that remdesivir, molnupiravir, and Paxlovid may have therapeutic value against the Omicron sublineages BA.2.12.1, BA.4, and BA.5. And this is also true for bebtelovimab. These drugs, as I previously mentioned, may have limited application in our local setting, however. Remdesivir may offer another option for prevention or progression to severe disease among at-risk patients. Philippine COVID-19 living recommendations suggest the use of remdesivir in non-hospitalized children with COVID-19 with at least one risk factor for disease progression. The risk factors, for example, are cardiovascular disease, immune compromise, obesity, chronic lung disease, chronic liver disease, and all these indicated here. It is indicated in adults and children 28 days of age and older and weighing at least 3 kilograms and with confirmed disease who are within 7 days of symptom onset and who are at high risk for progression to severe COVID-19 and non-hospitalized, with the dose as seen here, and it is given for 3 days only. This being an IV drug, of course, poses its own challenges. In my experience, I have given remdesivir in mild to moderate COVID cases who are hospitalized but for a different reason and who get COVID when they are already admitted. Patients with moderate, severe, or critical COVID-19 should be admitted. Specimen collection must be performed with assistance as the child may be uncooperative. The child should be admitted in an isolation room or in a dedicated COVID-19 ward with healthcare workers wearing appropriate PPE. Supportive care is the mainstay of therapy for patients with severe or critical COVID-19. Most children will improve with supportive care, even those with severe disease. Respiratory support, including supplemental oxygen and ventilatory support, should be provided as necessary, as well as fluid and electrolyte support. There should be rational use of empiric antibiotics as indicated for community-acquired or healthcare-associated pneumonia. Bacterial co-infections appear to be infrequent. Monitoring for cytokine release syndrome by monitoring blood pressure for hypotension, oxygen saturation for worsening hypoxemia, and biomarkers should be done. The following laboratories should be requested as part of evaluation for monitoring and as well as for prognostication. Therapeutics for severe and critical COVID include corticosteroids and the interleukin 6 inhibitor tocilizumab and the Janus kinase inhibitor baricitinib. These three function as immunomodulators. Remdesivir, on the other hand, may be used in severe cases. The WHO Living Guidelines makes a strong recommendation for systemic corticosteroids in patients with severe and critical COVID-19. Dexamethasone is the most studied and the most commonly used, with the dose and duration as seen here. Listed also are the alternatives and their doses. Tocilizumab is also a recommended therapy for severe and critical COVID. It is indicated for patients showing rapid respiratory deterioration and or requiring high doses of oxygen and with elevated markers of inflammation, and should be used with corticosteroids. The dose is shown here. The Philippine COVID-19 living recommendations also recommend corticosteroids and tocilizumab, just like the WHO, corticosteroids for those with severe and critical COVID-19, and the addition of tocilizumab to systemic steroids in patients with moderate to severe COVID. What is new in the WHO guidelines is the strong recommendation for baricitinib in combination with corticosteroids in severe and critical COVID-19. Baricitinib is recommended as an alternative to tocilizumab. The WHO acknowledges that data on safety and efficacy in children and pregnant and lactating women is lacking. The Philippine recommendations have not made an evaluation of the evidence for baricitinib in children yet. In the US, it has an emergency use authorization for the pediatric age group, but its use is limited, again due to the lack of data in children. Baricitinib has a certificate of project registration in the Philippines, but the indication is not for COVID-19. So it would be best to refer to a specialist for its use as an alternative to tocilizumab for severe and critical COVID-19 in children. Remdesivir remains to be considered as an investigational therapeutic intervention for severe COVID, in contrast to steroids and tocilizumab, which are recommended therapy. It is indicated for severe COVID because studies show that there seem to be no benefit for those already with critical disease. The dose is the same for what we discussed earlier for mild and moderate disease, but the duration for severe disease is 5 to 10 days, with some observations saying that the 5 days duration lessens the risk for adverse drug events. Thromboprophylaxis in pediatric COVID cases should be on a case to case basis and not routinely given, unlike in adult patients. Presence of risk factors or markedly increased D dimers, as well as consultation with hematology, can guide initiation of anticoagulation. The PSP guidelines recommend thromboprophylaxis if the conditions listed in the table are present, while the Philippine Living CPG does not recommend routine anticoagulation in children. So it's best to consider these on a case to case basis. Let's now pivot to MIS-C. Unlike acute COVID, MIS-C is a sequelae of SARS-CoV-2 infection, and let's differentiate them. MIS-C is often described as similar to Kawasaki disease, but it occurs more frequently in older children, whereas severe COVID can occur in the very young and in older adolescents and in those with underlying disease. MIS-C can involve multiple organs. GI symptoms are more prominent and some can go into shock, which are less often seen in Kawasaki. Myocarditis can occur both in MIS-C and severe acute COVID, but respiratory involvement is more common in severe acute COVID. The inflammatory response is much elevated in MIS-C than in Kawasaki, or the cytokine storm in acute COVID. So the similarities in the profile of MIS-C and KD have led to similarities also in their treatment. The treatment for MIS-C entails corticosteroids as immune modulators. Methylprednisolone is given in the doses indicated here. IVIG with corticosteroids may also be considered. Aspirin and additional thromboprophylaxis are given as indicated. The WHO living recommendations makes a conditional recommendation to use corticosteroids in addition to supportive care in hospitalized children with MIS-C. That's in contrast to either IVIG plus supportive care or supportive care alone. Multiple organ involvement would entail a multidisciplinary team to address MIS-C management. Once afebrile for 48 hours and with resolution of most respiratory symptoms, most patients can complete their isolation period at home. Follow-up is important. The AAP recommends follow-up based on severity. This severity criteria is different from one with what we mentioned earlier. So a patient who had moderate disease described as greater than 4 days of fever of 38 degrees Celsius, greater than 1 week of myalgia, chills, or lethargy, but was not ICU admitted, or severe disease, those who had an ICU stay or intubation, may be at greater risk for subsequent cardiovascular disease. Therefore, an in-person visit is recommended for these patients with moderate or severe disease. For asymptomatic or mild disease severity, a follow-up visit by phone or video may be sufficient if all residual symptoms are resolved. If a patient is not yet vaccinated against COVID, they may be offered this after ending their isolation period or 90 days after receiving monoclonal antibodies. There are local DOH guidelines for this. Return to previous physical activity, return to school, return to sports need careful consideration, especially for those who had moderate or severe disease. There is this algorithm for the AAP for return to play, and there are important screening evaluations recommended, especially for cardiac status, that needs to be made before a child who recovered from COVID is allowed to resume physical activity because some symptoms can persist. The most common residual symptoms are lingering cough and fatigue. Myocarditis can affect cardiac status post-infection. The list here is important to note so that children who report these residual symptoms can be referred to specialists or given supportive treatment. Or if these symptoms linger for longer, a diagnosis of long COVID or post COVID conditions may be present. Long COVID is defined by the WHO as occurring in individuals with a history of probable or confirmed COVID infection, usually 3 months from the onset of symptoms that last for at least 2 months and cannot be explained by an alternative diagnosis. Symptoms may be new onset following initial recovery from an acute episode or persist from the initial illness. This data from a meta-analysis of studies in children shows that up to 25% may have long COVID, with neuropsychiatric symptoms the most commonly reported. This condition is still being defined, so its management would entail recognition of its symptoms and that physicians should not dismiss these patients if they report them, so that proper investigations may be made and referrals and follow-up is instituted. Let me wrap up by connecting the discussion to our case. We know that patients with chronic pulmonary disease are at increased risk of morbidity and mortality from COVID-19, and so prompt diagnosis and treatment is needed. Those who are classified as at risk for severe disease or those with severe disease may have therapeutic interventions instituted along with supportive care. And even though we did not discuss this, we know that vaccination against COVID-19 should be given to children, especially those with chronic lung disease. Thank you and good afternoon.